Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. I'm your host, Eric Lim, and this week is a great delight for me to present Professor Julie Wu from California to talk to us about harnessing large language models to advance screening. As always, the Grand Rounds have been brought to you at no cost with premier education thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the sites of care. Julie, over to you.
Well, thank you for that kind introduction, and thank you everyone for coming, and to the organizers for the invite. It's an honor to be here. So my name is Julie Wu. I'm a staff physician in medical oncology at the Los Angeles VA and an assistant professor at UCLA. I'll be talking today about how we're using large language models and generative AI in medicine, and how we recently used it to address a 20-year-old data problem for the Veterans Affairs healthcare system. And so I just want to start with a poll. You can answer this at home. When you're using ChatGPT, how well do you think these tools like ChatGPT work today for most healthcare questions where it already has the data? Is it one, magical? Two, does it give terrible answers? Does it hallucinate explanations? Or three, somewhere in between? And just think about it for a minute, but I think the answer truly is actually all of the above. And so, one of the challenges in this space is it's very noisy. There are loud voices in here with very different takes. There's the dreamers who think that AI will solve everything. There's the doomers who think that AI will destroy us all. There's the skeptics who say that this is all hype. And then there's the snake oil sellers who are, saying like this will, this will miraculously cure everything that ails you. And I think the surprising part is that each of them is actually partly right. So all of their arguments hold in certain contexts. And I think one of the challenges of this field, especially, at least for me, is learning how to hold all these conflicting viewpoints in your head all at once. And so my goal today is to talk about these challenges in the context of a real life clinical problem. Just a quick outline of my talk, I want to start by giving context to generative AI and large language models. And I think I do want to address why, large language models and generative AI are, viewed as such a game changer. And I think, increasingly why everyone in this audience should be part of it. Next, I want to talk about how I use large language models to tackle a nearly 20-year-old data problem for electronic health records in data science, where I currently sit. So personally, as a member of the Veterans Affairs healthcare system, I'm excited about what opportunities and challenges we will face in scaling these large language models in the nation's largest integrated healthcare system here in the U.S. And so, first, what is generative AI? And so, I think, for generative AI text models, so these are large language models that predict the next word in a sentence. So essentially, this is a statistical autocomplete. And it's crucial to remember that, for these things that like talk to you like a person, when you interact with them, they're actually not thinking, they're not planning, they're not solving puzzles, they're actually not intelligent. They're just predicting what the next most likely thing is based on what they've seen before. And so, it turns out actually you can get pretty far with just that when you train it on one of these models on, say, like the entire internet. And so when you imitate what intelligence looks like closely enough, you can do really useful and interesting things. And so I'm going to take you back a couple of years. November 30th, 2022, that was when ChatGPT was released. And, a few months later, in February 2023, we got this headline of, ChatGPT was passing the USMLE. And I think that this was one of the first demonstrations that these large language models could reason as well as a human in this medical context. And so since that initial release, I think we've had just like a rapid expansion and just like, I think like every day there's a new and improved model. And so, the newer models can not just pass, but readily outperform humans, getting 100% on, I think, on recent scores on these multiple choice tests. And so with each release, I think the reasoning power of these large language models has increased at a palpable pace. And, I think also one of the, really transformative things about these large language models is that they're available to pretty much anyone with an internet connection. So they're accessible to everyone right now. And increasingly, you can run these models on patient data, including here in the VA. But this stuff is actually surprisingly hard to use. And so I think this is well illustrated by a study done by a group out of Stanford, where I did a lot of my training, and I was there most recently. So in this study, the authors randomized physicians to answer questions about clinical vignettes. So importantly, this was like the USMLE and other standardized tests in that it was a standardized test. So, they were given, pretty typical test questions. But unlike those standardized tests where you have multiple choices, they actually had a free text response. So they would give you a patient presentation and then, say like, what do you want to do next for management and such. And so, I think we've all gone through, a lot of us have gone through medical training, and we can remember those from back in our background. And so, the physicians took this, and they were allowed to use this, standard tools that we generally have, things like guidelines, up to date. But I think that for one group of physicians, they actually also allowed them to access these new modern large language models with ChatGPT. And so here you can see the scores of these physicians who did it. So you can see that in green, that when you added ChatGPT to these conventional resources, that you did get a slight improvement in overall scores in your answers to these clinical vignettes compared to conventional resources alone in blue. But I think the surprising thing from this study was that, they actually just ran the vignettes through ChatGPT without the human in the middle. And they found that ChatGPT actually did better than both groups. And so I think this kind of turned over, some of this conventional wisdom on your head, which, like typically when we think of these tools, we think, okay, you take the tool and you take a person, and without that person's like expertise and sort of experience, you will get better performance out of the tool. And maybe that's not the case. So this study is now 2 years old. I think there's been increased awareness about how to use tools like ChatGPT. I think what that study truly illustrates is that the performance of the tool is really truly highly dependent on how you use it. So like what questions you ask and how you prompt it. And so I think the lesson here is really that power tools like ChatGPT do, reward power users. So I think that, the good news, I think everyone here can be a power user. Everyone here can be a prompt engineer. The key is just, hands-on time, learning how to ask questions and learning how to use it. And this may sound like a lot. And clinicians may be wondering where they fit. And I think the good news is that you don't need decades of programming experience. So, I've shipped code in languages I didn't initially know well because, generative AI is really good at producing working code. Estimated 3/4 of the GitHub repositories are now AI produced. So I think this lowers the barrier to entry and lets us be more ambitious, so we can prototype faster, push ideas farther than what's possible. And I think this actually opens up possibilities too for those who are in this like data science fields, because historically code has always been expensive. Writing a few hundred lines of clean tested code could take a developer a full day. And I think many engineering and data science habits have evolved around that constraint. And so teams invest heavily in planning so that scarce coding time is spent efficiently. But, I think like things like Claude Code, these coding agents, they dramatically reduce the cost of turning ideas into code. And so I think this disrupts these kind of longstanding assumptions about what's worth building, shifts these trade-offs, making experimentation easier and just expanding what individuals can realistically create. And so, with that, I do want to transition to the second part of this talk. So, I think developing a base for operational clinical implementation pipelines, I think, is the focus of the second part of this talk. So, smoking history extraction has been this longstanding natural language processing challenge that had remained unsolved at the VA for decades. Just a personal anecdote, it was a consistent point of feedback for some of my early grants. And fortunately, actually, my grant submission coincided with the rise of generative AI. So this breakthrough not only helped unblock this problem, but I think it also opens up new possibilities for clinical problem solving and data science. And so, the reason why it kept on popping up is that smoking history is a key criterion for determining lung cancer screening eligibility. And unfortunately, I think it's part of the reason why lung cancer screening has lagged behind other screening programs. So here you see the uptake of various cancer screening at the U.S. over the years. And so, by most estimates, fewer than 20% of eligible individuals have participated in lung cancer screening here in the U.S. And unlike screening programs for breast or cervical or colorectal cancer, which determine eligibility based on age and gender, lung cancer screening also requires assessing age and detailed smoking history, including pack years and quit duration. And so, this complexity has been contributed to both organizational level and physician level delays in adoption. And so, here at the VA, I'm proud to say there's been actually significant nationwide organizational investment in lung cancer screening infrastructure. So we have a dedicated program to manually enter in the smoking history into operational pipelines. And so when that structured operational smoking data are available and indicate eligibility, actually most veterans go on to receive a lung cancer screening CT. Despite these efforts, though, estimated 200,000 potentially eligible veterans still lacked smoking history in the electronic health record. And so, if we assume that lung cancer incidence rates are similar to what we observed in the national lung screening trial, this gap actually translates to more than 2,000 potentially missed cases per year. And so, I think that one of the things that we saw with the rise of these large language models is that NLP has the potential to automate away all that manual data entry. So I think this has been a long-standing challenge in smoking history is finding a way to get that because oftentimes even when the smoking history isn't in that operational pipeline, it's actually available in our notes. And so, one of the things that we can do with these large language models, like a ChatGPT interface that you see here, is that we can just prompt it and we can just ask it, what is the smoking history in this note? And it actually gives you a pretty good answer. And so, I think that we were encouraged to try again. And so, I think with enough time and effort, again, the smoking history NLP challenge has been around since the 2000s. So it's a 20-year-old data challenge. You can address this with, the traditional methods. But a major barrier to the broader adoption has been the lack of generalizability. And so the models that work well in one health system actually kind of fail elsewhere. And so this is actually work back in my residency at Vanderbilt. In response to the NLP smoking challenge, a team at Mayo Clinic actually developed a rules-based algorithm that actually achieved like 90+% accuracy on their training data. But when we tried it here at Vanderbilt, we applied the same algorithm and the performance dropped to like 52%. So it was essentially no better than a coin flip. And I think this highlights two key issues. One, models trained on one data set using these traditional methods may not generalize to other, but even more importantly, I think it's that these models that are used to traditional data sets or traditional methods break over time. So let's say you record your smoking history in like one specific form, and then the format of that form changes. The model may no longer work. And so even if you are staying at the same institution, you have to constantly update and fix this model. And so, one of the central challenges for deploying these clinical NLP models in operations is, how do we build models that are not only accurate, but robust? And so, I think that with this in mind, we did evaluate the performance of a small deployable open source large language model on 5 key components of the smoking history. So status, duration, quit year, intensity, and pack years. And so we began by testing, just like the standard basic prompts, similar to like just saying like, hey, like what are the smoking pack years from this notes, to see if they would work out of the box for this smoking history extraction. And so, on the left, you can see the F1 scores. So another measure of accuracy across 2 data sets. The VA in green, Mimic in blue. Mimic is just a public data set that's actually, from a different institution. So we were testing cross-institution generalizability here too. And so while these prompts were actually outperforming historical non-large language baselines, we still were observing variability between the two data sets. And so I think this highlights a critical point that, large language models do not, especially, this is actually highly model dependent, what I'm about to say, but, they don't necessarily inherently generalize across institutions or data sets without some work or tweaking. And, this is actually a specific point to the smaller models. And, I think for some of the more large models, this is not necessarily true anymore. But after prompt engineering on a small actually data sample, we actually improved overall performance across tasks and institutions. Not directly shown here is that actually represents, over 100 healthcare systems, more than a decade apart, and so through honestly, just like prompt engineering, which is, again, accessible to everyone here, we're not only able to improve performance, but also reduce variability in performance across these institutional data sets. And so, now that we have these systems to extract node data, we can use it to actually resolve other conflicts in the data. So this is work led by my mentor, Summer Han, out of Stanford, published in Nature Digital Medicine, where they show that having this node data about smoking can actually resolve conflicts in, even the structured data that we see. And so here we're looking at quote unquote implausible transitions in smoking status. So, for example, when a current smoker is suddenly recorded as being a never smoker. And so here we see example sort of patient timelines of smoking status, where the recorded status is red for current, orange for former, blue for never, and the implausible transitions are kind of listed on those bottom rows. And so when a transition occurs in structured data, so going back to the node data actually enables this sort of smoothing so that the data inconsistencies are resolved, and you can actually get higher quality results using this method. And so now, empowered with this smoking NLP algorithm, we actually ran it on a test cohort of veterans who had actually later been diagnosed with lung cancer. And we found that, actually 58% of them had sufficient information in their notes, just, about their smoking history to determine eligibility at a median of about 1 year prior to their diagnosis. And we actually compared that to what was available operationally at the time for, the same cohort. And it turns out, that there was a lot of missingness. And so the structured data was only available for 8% of that same cohort. And so this represents a potentially greater than six-fold increase in the number of eligible patients that we can capture for screening. So, using screening as a test case, we can now show that we could solve these long-standing data problems. But I think this is just the beginning. That models are evolving rapidly, expanding what is possible. And I think critically, actually, for this audience, regardless of how much testing has been done, these models are already being deployed in these healthcare systems, but there are still unknown limitations. And so these limitations will only emerge when we test against real clinical needs and real world data. And so I think for us as clinicians, I think as we move not towards the question of like, will there be a robot doctor, but how do we build a robot doctor? I think having clinician involvement will be key to getting it right. And I think just need careful building and evaluation in real clinical settings. And so with that, I would like to, thank everyone here for their attention. I would like to thank an amazing team that I've had the privilege of working with, and I'll leave it there. Thank you.
Excellent. Thank you so much. So Julie, just to reiterate, you're using the large language models to actually sift through electronic patient records in the whole Veterans Admin hospital system?
Yes.
And the pickup rate you mentioned is quite a small percentage of the eligible for screening?
Yeah, so I think that historically, and again, like we've made more recent investments in our screening infrastructure. So this is of a historical sample. But historically, the data entry for smoking was manual. There wasn't a lot of direct feedback about the smoking history entry to the person who was entering it, and so. There was a lot of missingness in terms of being able to capture these in an operational fashion.
Have you experimented using broader data sets, family medicine kind of data sets, rather than hospital data sets alone?
Yeah, so actually, I think that's one of the beauties of this approach is that I think really because the large language models work in settings really quite easily and rapidly. That I don't think the challenge is so much making models anymore. I think the challenge is really just getting models on your healthcare data, and so that I think it shifts the problem a bit.
So just like how the large language model summarize documents for us, what you're saying is that the ability to summarize the actual smoking risk factors, presumably principally you're using number of years of smoking as the principal screening method.
Yes. So we do use smoking history. So the number of years, the intensity, the product of those, which is the intensity times the duration, the pack years, and then the quit duration.
Does the data need to be structured in any way for the LLM to better pick out those who are at high risk?
That's actually, I think, one of the beauties of this actually is that, I think traditionally, yes, increasingly no, right? So that's actually again one of the amazing flexibilities of these models is that they can handle data in a variety of formats, and so you can really I think the possibilities for all these distractions are quite limitless at this point.
Yeah, because I'm just thinking as the NHS in the UK move more towards electronic health records, large language models to extract high risk smokers would definitely be a really important step going forward. Can I ask, in the UK, right, we've got this big issue about confidentiality. Google DeepMind originally used data from one of the hospitals, the Royal Free, and they didn't get any patient permission to try to develop a model to predict acute kidney injury. Are there any issues about patient confidentiality, use of data within your hospital systems that could be violated if an LLM is interrogating their electronic health records?
Yeah, I think that's a great question. I think that's actually one of the key challenges with this. So I think there's an important distinction that I didn't mention. So there's the sort of ChatGPT version where we are sending the data out to a different server, and that is then evaluating it and sending it back. But there's also the open source models, which you can download and actually run within a closed system, like your healthcare system. And so that's actually what we use. We use an open source model that we downloaded. We use it all within the healthcare protected healthcare firewall. And so that so that is increasingly possible because open source models are actually increasingly just as powerful as the closed source models, which require a connection to, again, these external servers.
And can I ask, how do you communicate this to your patients when you invite them for screening? Do you say that we picked up, or do you say our hospital systems or a large language model picked up your risk?
Yeah, so I think that's actually a great question. So we started with the smoking history because I think it's a very defined, tractable, problem in many ways, right? So we're using a slightly more advanced technology, but in reality, it's just an advance on prior methods. We're essentially just using the ChatGPT to read their notes in the same ways that traditional NLP methods have read their notes in the past. But I think it is an important concern is how you communicate this to patients. And I think that things like reliability, trust, evaluations for bias, all of those are going to be important in the years to come to make sure that we maintain that trust.
But a question from the audience was asking if it's possible for the large language models to develop a more sophisticated algorithm for the individual parts, like the PLCO or US Preventative Task Force risk modeling for lung cancer risk.
I think that's a really interesting question. I think for me, I actually, I separate this out into two parts in my head. So one is the data extraction and the other is the model. So I think that for data extraction, I think that like smoking history has been one of the challenges with using these models on electronic health records, and so I think that that is increasingly solved by large language models. I think for the model itself, I think those are more defined, and you don't necessarily need the large language model to calculate the model itself, which again has been well defined. But for just like getting the variables into the model, I think that that the large language models are definitely opening up possibilities there.
Possible is what you're saying.
Oh, yeah. So I think that it just enables both validation and implementation potentially on a larger portion of the population than historically we've been able to reach.
Dr. Therese is asking, is it possible for the model to incrementally improve itself as it learns? Is it self-learning, or is it just a static model? The large
Oh,
language
that
models.
is interesting. So let me think about that. So I think that there is a portion of what we do is that we are increasingly in the age of agents, and so the age of agents is changing what we can do with these large language models. So the agents are autonomous, essentially programs that can do things like write code. And I think that it is entirely possible for this model to be self-evolving, self-correcting in some ways in response to feedback or other inputs.
Yeah, because like sometimes Claude gets the dates wrong. Claude's always confused, for my experience, always confused about the dates, right? I'll say like, no, Claude, today's Thursday, it's not Tuesday. And then they get a really sycophantic answer. Oh, thank you, you're right, you're pointing that out. I'm wondering, but does Claude actually learn if another user comes in and says, hey, Claude, what's the date today? And they'll say, actually, it's Thursday and not Tuesday. I don't know if it's, like you said, it's more like a stochastic parrot, fill up, auto-fill. And if you point out a mistake, whether they actually learn or just give you a polite answer, it's a very black box at the moment.
That's actually that's a great point. And so actually, you are absolutely correct that the large language models are still very bad at dates and very bad at math. And so that's part of the reason why separating out the data extraction and the modeling sometimes might help. I think that you are correct that there are known limitations of large language models, but you also see where this is going, right? Like we're barely able to pass the USMLE, 3 years ago, and who knows where it's going next.
Yep. So Dr. Chukang's asking, with the closed models, you don't have access to the full internet or data or updated guidelines and so on and so forth. Is it at risk that the closed models within your hospital systems won't be as, say, progressive or has as wide a knowledge base if it was an completely open model?
Yeah, I think that's a good question. If I understand correctly, that the beauty of the open models is that they can call agents to query. So like things like open evidence, where you can query the internet, and you can also get back updated citations in real time. And the closed models, you are still reliant on the manual entry of guidelines and other data sources. I think that is a reasonable limitation of the closed source models. And I actually do think that that's actually one of the difficult regulatory challenges, is how we can keep up with healthcare data and the necessary requirements for privacy while still maintaining relevance to all the advances that are going on today.
Yeah, a super exciting field. I just want to congratulate you on really pushing the field forwards in such contemporaneous research, which I'm sure is going to impact and influence all of our practices going forward. Last thing to say is that we're going to take a break for 2 weeks, because next week it is the British Thoracic Oncology Group meeting, followed by the week after by the Society of Cardiothoracic Surgeons meeting here in the UK. And we'll come back on the 20th of March, starting our radiotherapy series with Dr. Nakamura about proton beam therapy advances. Leaves me once again to thank our sponsors, AstraZeneca, Medtronic, and Medela. And once again, especially to you, Julie, for staying up till midnight to join us today on such a fantastic talk. Thank you so much.
Thank you. Thank you for the invite.
All right, bye-bye.